Now we're going to show how to use the Suzy hood with non-invasive ventilation using the Mindray SV800 ventilator. When the ventilator is first started, it usually defaults to an invasive ventilation mode, and we need to change that to a non-invasive ventilation mode. And you need to check that you've got an adult patient of the appropriate weight. And what we're going to do is, normally when we're using NIV, we would tend to set a PEEP of around 5, but we're going to start with a minimum PEEP of 10, and that's just because that allows higher flows through the helmet, which should reduce any risk of CO2 rebreathing. Similarly, it would be typical to start with a pressure support of 5 to 10, but we're going to start with 12 because, again, that reduces the risk of rebreathing by increasing the flow. The other thing we're going to do is put the inspired oxygen up to 60% to start, although we will wean that back once we're happy that everything is stable. So, having set our base settings, we need to check our humidifier is on. And we're using the Fisher & Paykel 950. And we're going to set, it's important to note you may have to vary the temperature that the humidifier is set at, because if you have this into the mid-30s, as would be typical, you often get condensation forming on the hood, and you often need to reduce the humidification temperature. So the next thing we're going to do is put our patient into the Suzy hood. Would you like to close your eyes, Max? The next thing we're going to do is place the straps under Max's arms through the appropriate part of the helmet frame, and then we're just going to tighten them, making sure that the padding is under the armpits and the patient's comfortable. So we've now put the free breathe valve on, the inspiratory and expiratory parts are open, and we've inflated the head and neck cushions. If you want to see this in depth, watch the Suzy hood CPAP video. We're now going to attach the inspiratory and expiratory limbs of our Mindray ventilator to the helmet. And it is important to check before you start that you have viral filters on the inspiratory and expiratory ports of your ventilator. And now we're going to start ventilation. You can see that at the moment the readings that we're seeing in the ventilator screen are atypical. So we're seeing, for instance, tidal volumes of 1700 mils and minute volumes of 20 and higher litres per minute. That isn't what the patient is receiving, that's what's happening inside the helmet. And so one of the things we do like to do is just check that there's no CO2 rebreathing. And one of the ways we can achieve that is by attaching our capnograph to the distal side of the expiratory filter. Because all the gas coming to the capnograph is coming from the helmet, we expect to see that the CO2 levels should be down, ideally beneath 6 millimeters of mercury. If they were to rise and to stay elevated, or to be seen in a rising trend, we may need to increase our pressure support and PEEP in order to increase flow through the helmet. So as we're achieving CO2s that are low, and we have had a little bit of leak around the helmet, we've already started to reduce our FiO2. We've taken down our pressure support slightly, and I'm just going to reduce the PEEP down to 8. And as long as our minute ventilation is looking up to be in the 20s, and we see that the CO2 is nice and low, we are not concerned that there is any rebreathing.